This is EHJ today at the annual scientific sessions of the American Heart Association in Chicago 2014. I'm Tom Luescher, Editor-in-Chief of the European Heart Journal, and I'm discussing the Texas Liberté prasugrel trial with its PI, Kirk Garrett from Lenox Hill Hospital in New York. And we also have a discussant, Michael Gibson from Harvard Medical School in Boston. Welcome, gentlemen. So Kirk, tell me what made you do this trial? What was the hypothesis, the thoughts behind it in this particular case?
Sure, thanks, Tom. This TLPAS study is the Texas Liberté Post-Approval Study. That's an aftermarket registry that the FDA requires so that we can provide information about how well an approved stent is working in a new market in America. While that was being constructed, Laura Mowry, Dean Kariakis were assembling the dual antiplatelet therapy study. Through agreements negotiated with FDA, the four principal stent manufacturers in America provided patients to the DAPT study. One of the manufacturers was Boston Scientific. Boston Scientific agreed to provide their Liberté patients from the TLPAS registry, feed those patients into DAPT. Additionally, FDA agreed that all of these Liberté patients could be treated with aspirin and prasugrel. That was done to assure that DAPT had an adequate representation of patients treated with both prasugrel and clopidogrel in their study. As the course of the study was taking place, we had supervision of the patients in TLPAS through our TLPAS Data Monitoring Committee. And of course, DAPT had a data monitoring committee looking globally at the information they had. In mid-2013, the Data Monitoring Committee for TLPAS alerted me and Dr. David Lee, the co-principal investigator for the TLPAS activities, of a concern. They alerted us that there was a safety concern among these patients and recommended that we as the principal investigators be unblinded to the data and consider their action. What we observed has now been made public. They observed a significant increase in the rate of accrual of adverse events among patients who had been treated with prasugrel when the prasugrel was discontinued.
When was that, time-wise?
So according to the construct of the DAPT study, which we conformed to, patients got the stent. They were treated then for 12 months with open-label drug, in this case aspirin and prasugrel for everyone. At that 12-month mark, patients who were event-free and who consented to participate then were randomized. They either continued active prasugrel but now in a blinded manner, or they were given placebo.
Right. For another 2 years? Or?
For another 18 months, for a total of 2.5 years of therapy from beginning to end. What our data monitoring committee observed was that after that 12-month randomization time, the event rates between the two groups separated quickly. Within 90 days, there was a very important difference in adverse event rates, with many more events being seen in the placebo-treated group. However, the DMC said, this is why we were here, this is why we came, this is the nature of the study, we will accept this observation, and there were no stopping rules that required any change in the process based on that observation. We continued then to participate in DAPT and eventually got to the point, the 30-month mark, that allowed us now to stop study drug in patients. When we got to that point, we discovered that the patients who had been assigned continued prasugrel treatment, who now had that prasugrel newly withdrawn, they also had a very sharp rise in the rate of adverse events.
So it was very reproducible.
Pretty much what we saw at 12 months, we saw again at 30 months. At that point, the Data Monitoring Committee said, listen, we need to alert investigators and unblind therapy so that patients who were assigned 30 months of treatment would have an opportunity to talk with their doctors about whether or not they wanted to continue open-label prasugrel beyond 30 months. And that's essentially what we came to this AHA to report on today.
So what do you think about the data, Mike?
I'd like to congratulate Kirk and the DAPT investigators. I think this is just an absolutely seminal observation. It reproduces some of what we saw in Triton, which began prasugrel early on in the setting of ACS, but this is clearly in the secondary prevention period, out at a year. To this point, we've had a lot of smaller trials that have indicated that we could stop dual antiplatelet therapy earlier and earlier and earlier with newer generations of stents. I think there's been a tendency for us as interventional cardiologists to want to treat the stent, but what Kirk's results highlight is there's a patient, and the disease is chronic, and you know that the events continue to accrue beyond a year, and that we must probably continue, I think personally, the therapy chronically. I think also the fact that when you withdraw the therapy, you see a resumption of events is yet another piece of evidence that says chronic therapy in these patients is warranted. Now, I know a lot of guys out there are saying, what about the bleeding? Exactly. But I will say this, there was no excess risk of bleeding in this trial. Very importantly, they did a great job of focusing on those patients in whom the label supports use. People who are under 75, over 60 kilograms, no prior stroke or TIA, it was safe. Yes, there is some excess bleeding, but not the kind of bleeding like fatal bleeding or ICH that gives us the most pause. Finally, I think the other critical observation is the MIs that were prevented, 55% of the MIs that were prevented weren't stent thrombosis.
They were in other vessels.
They were spontaneous MIs. So again, we have to move from just treating stents to treating the chronic disease state in these patients, which eventuates in a large number of MIs late. And that withdrawal data, Kirk, is very interesting because all of us have seen 2 years, 3 years out, someone who stops their drugs for a dental procedure has stent thrombosis, and you now quantitated that risk in this study.
So it's more like a secondary prevention after a while, isn't it? So in the guidelines of the European Society of Cardiology published in this patient population, they actually they recommend prasugrel primarily for ACS patients with the restrictions you just mentioned. And as regards dual antiplatelet therapy in general, they even allow for 6 months. And this is based on the smaller trial by Valimili, but also the trial by Castrati and co-worker presented here in Chicago. So the larger registries and trials, like the DAPT trial, shows, of course, something else because they have more power to detect the events also in the long run. And so should we reconsider the guidelines?
It's a very tough question, of course. In Europe and in America in 2014, I think practitioners were getting increasingly comfortable with the idea of using shorter periods of dual antiplatelet therapy in the belief that that was not just safe, but optimal care. I'm not sure that DAPT can overturn any of the notions about safety. We've had enough experience with short-term dual antiplatelet therapy to have confidence that for the majority of patients it will be a safe option. But that's different than defining optimal care. I interpret our experience with the Taxus Liberté and prasugrel subset and the larger DAPT study to teach these important lessons. When you have low-risk patients for bleeding who are capable of taking drugs long-term, there is value in doing so. The principal value is that you will prevent heart attacks, not just those related to the stent, but heart attacks related to their disease, as you point out.
It's the natural history of
cardiac disease. Natural history of the disease. Secondly, we have to be attentive to the fact that when we stop the drug, perhaps at any moment, 6 months, 12 months, 30 months, there is the chance that we will see a significantly accelerated rate of event accrual. We don't understand what's behind that entirely, but we must be cognizant of it, and that has to be factored in to our decision making. And then finally, I think the important point is that we started these efforts in order to understand what we needed to do to prevent blood clot on stents. We can really manage that with a prolonged therapy, dual antiplatelet therapy strategy. But we saw in DAPT and in my subset of DAPT that we can anticipate benefits that go far beyond just blood clot on stents.
Right.
If we embrace a longer-term care plan in low-risk bleeding patients that can tolerate the drug without significant risk of hazardous bleeding.
So it needs a good doctor to decide whether or not it's useful for the patient to continue, and I think the balance has really shifted to a more prolonged treatment after what we've seen during this meeting. Thank you very much, gentlemen.
Thank you.
Thank you.